make a start. So my name's Frances. I'm the anaesthesia nurse here at MediPaws, and our other presentation is going to be by Mel. She's one of our surgery nurses. Thank you all for coming. We are hoping to make this a semi-regular thing of nurse education, just to give back to our lovely referring vets, and also because it's good to do continuing education. So hopefully we will see you at our next ones if you enjoyed tonight. And thank you to everyone who's attending online as well. It's good to see everyone out there. So basically tonight is kind of a blood pressure night. So the first talk that I will do just kind of is going to run through some fundamentals on blood pressure, and then Mel's going to cover what we do when our patients are hypotensive under anesthetic. So what we're going to cover tonight with me is what is blood pressure, how we calculate blood pressure, what is an adequate blood pressure, and how we measure it both invasively and non-invasively, and the pitfalls, limitation, and best practice techniques for each method. So what is blood pressure? So blood pressure is essentially the force that the circulating blood exerts on the walls of the arteries. It's determined by cardiac output and systemic vascular resistance. Changes in either of these, for example, during anesthesia, when we have some vasodilation or the heart rate decreases, will directly influence blood pressure. So blood pressure is used as an indirect way to measure cardiac output and tissue perfusion. Measuring the blood pressure and maintenance of sufficient blood pressure is probably one of our most important goals of good anesthesia practice. And as a rule of thumb, you can kind of go, the higher the blood pressure, the higher the cardiac output of the patient will be, and the better the tissues are perfused. And I don't know why that slide is repeating itself, but there we go. It's going to do it for every slide for some reason, and I don't know why. So blood pressure is at its highest when the heart contracts, and that's what we record as our systolic arterial pressure. And it is at the lowest when it relaxes, which is what we call our diastolic blood pressure. And then the mean pressure is an average pressure on one cardiac cycle, so contraction and relaxation. So we can express blood pressure using this formula. So it's blood pressure equals cardiac output times systemic vascular resistance. So cardiac output itself is influenced by the heart rate and stroke volume of the heart, and vascular resistance is influenced by our vessel diameter and the tone of the vessel. Understanding what blood pressure actually is will guide how we treat hypotension and whether it's more appropriate to give fluids, adjust anesthetic depth, or reach for our vasopressors, which Mel will go through in the next talk. We can also have a neat little calculation as to how you can calculate your mean if you only have a machine which does your systolic and diastolic. So if you don't have a machine that gives you a mean, you can calculate it by doing 2 times your diastolic plus your systolic and divide that by 3, and that should give you a mean arterial pressure. You can also check your machines sometimes by doing this on your non-invasive machines, see how accurate it is. So what is adequate blood pressure when we've got a patient under anesthesia? So we do aim to keep our adults at a mean arterial pressure of above 60 under anesthesia. Our pediatrics, we can kind of aim to have them above 50. I don't know if you guys have ever tried to anesthetize something very small. It's really hard to keep their blood pressure up, but they do quite well with a blood pressure above 50. Most vital organs do auto-regulate with a blood pressure above 60. So like everything will keep ticking on, your kidneys, your brain, your heart, your lungs, everything will just kind of auto-regulate with a blood pressure above 60. And when it goes below that, that's when your brain and your kidneys and everything can become a bit vulnerable to hypotension. So you can tolerate probably short periods, around 10 to 15 minutes of hypoperfusion, but beyond that, there is risk of permanent damage. So maintaining your MAP is essential for patient safety. Detecting organ damage due to hypotension can be difficult. So if you have a cat spay at 6 months old, that's hypotensive. I mean, cat spay is a bad one, but say if it was under anesthetic for an hour and it was hypotensive for an hour, there is a chance that we have caused some kidney damage during that time, but we will not see that until they're older, because the kidneys, you have 70% have to be damaged before the kidneys will show that they are damaged. Sorry, in blood work, yeah, and clinical signs. So 70% of that kidney will need to be damaged. So we just have to remember that every little bit of good blood pressure is good, because we don't want to damage the kidneys at all. And if we do have low blood pressure, we just want to keep it to 10 to 15 minutes of trying to elevate it the best that we can. Animals that are chronically hypertensive, so if you've got your old hypothyroid cat who's used to having a mean pressure of 120 at all times, damage will occur. The auto-regulation kind of becomes a bit like, yeah, that's what my pressure is now. So damage can occur at a higher number. So if you've got an older animal who's chronically hypertensive, you kind of want to keep their mean at a 70 or 80 under anesthetic, just because they're going to have more damage the higher the blood pressure than the lower, if that makes sense. I'm rambling, I'm sorry. So how do we measure blood pressure? There are many different ways to measure blood pressure. Each vary significantly in terms of reliability and accuracy. So we're just going to look at each method and how to optimize their use. So we have our non-invasive techniques, which are pulse palpation, Doppler, and our oscillometric. So pulse palpation is excellent for determining your heart rate and identifying pulse deficits. It is not a reliable way to estimate actual blood pressure. There are some older texts that say a femoral pulse suggests a systolic pressure of 60 and a dorsal pedal pulse suggests a systolic pressure of 90. This is not true and has never been proven, so please don't do that. It still wouldn't be very good either. No, it's not great either, but it's also not a way of measuring. The fingers can only feel the difference between the diastolic and the systolic pressure. So it either feels strong or it feels weak, but it can't give us a number. So we try not to use pulse palpation as a way to measure blood pressure. We do have our non-invasive Doppler. So Dopplers are very useful because they give us continuous audio feedback. From the sound, we can gather the information about heart rate, rhythm, and relative changes in blood pressure. So they work using a single probe that contains both an ultrasonic emitter and receiver called a piezoelectric crystal in the probe. That probe emits a sound wave and listens for the reflection of moving tissue. And the frequency shift that we hear is caused by blood flow velocity, and anything that interferes with that, like movement or tissue interference, can affect the quality of the signal. So this was supposed to come up one by one. Hold on, there we go. How do we use a Doppler? So we best clip the fur behind the metacarpal or the metatarsal joint. We'll get Abby in a minute and try it. And then we want to apply gel to that area to make sure and rub it in and make sure that it's nicely rubbed into that area. We then need to apply gel to the end of the Doppler probe. With the Doppler volume turned down so as not to startle your patient, place the probe on the clipped fur, not of the clipped fur, where we've clipped the fur. Turn the volume up slowly and listen for a pulse. When you do find that pulse, I always find it best to tape that probe then into place so it doesn't move the best that you can. And then we've got the cuff round the leg proximally to it. And with our sigmometer, we will increase that pressure until we cannot hear any more the sound of the pulse pressure. And then we release slowly release the pressure out of the sphygmometer until we hear the pulse again, and then we record that number. We will repeat this 3 times just for any number error or anything like that. So you get 3 numbers which are relatively the same number, and then you can probably stop, and that's probably a good blood pressure. So what do Doppler readings actually represent? So in our dogs, the Doppler reading is most representative of the systolic pressure. A pressure of 90 is acceptable under anesthesia. Extrapolating a mean pressure from a systolic is questionable, but a systolic pressure above 90 is likely to have a reasonable mean arterial pressure. Some studies do suggest that it reads about 13 lower is the mean arterial pressure, but it's not like this is science. It's just one paper, I believe. In cats, due to a difference in vascular compliance and signal differences, Doppler readings are more correlate closely with the mean arterial pressure. So a Doppler pressure of 70 to 75 is broadly accepted under anesthesia for a cat. So we'll move on to our oscillometric. So the oscillometric monitors work by inflating and deflating the cuff and detecting oscillations within the cuff as the blood flows through the arteries. These machines can estimate systolic and diastolic and mean pressures using algorithms. So the machine initially inflates the cuff to a pressure which exceeds systolic arterial pressure. As the pressure in the cuff reduces, the pressure in the cuff will oscillate, and you will see your machine goes through these numbers multiple times before it decides it's doing all of its thinking. And then, so the first detection when the oscillations have gone, that would be our systolic. When there's no oscillations at all, that would be our diastolic, and then it will algorithm the mean. So these machines are quite convenient, but can be prone to error, especially in our very, very small patients and patients that are hypotensive as well. A lot of studies have shown that they are very unreliable in hypotensive patients, unfortunately. So there can be lots of errors, as I just said. So the common errors include external movement. If your patient is walking around, you're probably not going to get a real blood pressure from them. So any pressure on the cuff can cause wrong readings. Restriction of inflation. So if your patient is positioned in a way that there's pressure on the cuff and the cuff can't expand, you will not get a realistic reading off the cuff. Arrhythmias, if your patient has a really hectic sinus arrhythmia where it's like a heart rate of 40 and then they take a breath and it goes up to 80, they really struggle to read the blood pressure. And weak peripheral pulses, so hypotension. But understanding these limitations can help us decide whether or not a measurement makes sense and if we need to repeat it or switch to maybe a different method like a Doppler to see what we're getting on the Doppler. So the importance of choosing the correct cuff size. So cuff size is crucial, and the cuff should be about 40% of the limb circumference. And many blood pressures have markings on the inside, which I'm sure you've all seen, of like how to size blood pressure cuffs on the animal. If your cuff is too small, the machines are going to overestimate your blood pressure. If the cuff is too large, they're going to underestimate your blood pressure. So you really want to have the best fitting cuff that you can. So cuff security. Best practice is to only secure the blood pressure cuff with the Velcro provided. However, we all know the Velcro provided kind of sucks after a while. Use it 3 times and it sucks a little bit. So a lot of people use tape or vet wrap to secure them. We shouldn't be taping all the way around, like shown in this picture. You can't really tell, but it's there. We shouldn't be doing a vet wrap around because it stops it from inflating properly, so you're going to get a wrong result. So if your Velcro is really crap, you can just get a little bit of tape, pop it over just the little outer bit, and then it should be able to inflate properly and not pop off because the tape's there. So that way is good, but best practice, use the Velcro. Cuff position. So the best cuff position that you can have is one where the cuff fits on the animal. So a lot of people like back legs, best practice, front legs, best practice. It's where the cuff fits best on the animal that's in front of you. So you need to make sure it's the correct size, it's secure, and it's not going to readily move. A cylindrical limb is always better than a leg that tapers. So like in your brachycephalics, you're going to have so much better success with it round the dorsal pedal than you are when they have it round above their hock, where they're just mush, really. Then they're not shaped well. So best just to pop it somewhere where it's cylindrical, either that or a front leg if they've got good looking front legs, and just fit your cuff to your patient. Choosing an area with less hair as well. So I would never recommend putting it around like a tail that's really, really furry, just because it's not going to be able to like get the pulse and the oscillations correctly. On the tubing, there is usually a little sign that says where the artery runs. It's usually very close to where you should put the line it up to the artery. It's usually close to where that tube comes out of it, and that's just going to give you the best readings as well. So always try and make sure that you are aware of where that bit is, because if it's on the wrong side, it's not going to give you the best reading that you can. All right, we are going to talk a little bit about invasive blood pressure. I know it's a bit more just like fun things. I know you guys probably don't necessarily have the means to measure invasive blood pressure in practice, but it is kind of the gold standard of blood pressure, so it's worth mentioning anyway and how it works. So invasive blood pressure is, as I just said, considered the gold standard, and it uses a catheter placed directly into the artery and connected to a pressure transducer to give real-time waveforms and highly accurate systolic, diastolic, and mean pressures. So the placement is technically challenging and does carry risks. So it's typically reserved for cases where continuous and accurate monitoring is essential. It is important to remember that arterial pressure read is dependent on the artery it is placed in and the vascular compliance, and the artery pressure in the peripheral vessels, so in our limbs, is usually not the same as it is in the brain, liver, or kidneys. However, the mean pressure is usually kind of standard across all tissues. So your systolic and your diastolic might not be what's happening in your vital organs, but your mean pressure should be pretty standard. So placing an art line. The most common site for an arterial catheterization in small animals is the dorsal pedal artery, and that is located medially on the hind limb. In cats, their tail artery is beautiful, like just goes because their little feet are so small that you have to use such a small catheter that it's not that great, but their tails are beautiful. So once placed, the catheter is connected to a non-compliant fluid-filled line and then to the pressure transducer. And you just have to make sure it's nicely secured, but I will just quickly go through the steps of how you actually place one. So first we collect all the equipment that we need. So make sure the T-port is flushed, and I am also a big flusher of the catheter before an art line as well. You can just see the blood come back that little bit quicker. I don't know if people do this with their intravenous catheters where they flush it first and then you can see the blood quicker. But it definitely works very well on arterial catheters as well. So you clip, if it's a dog, the medial aspect of the hind limb and aseptically prep, because obviously we're going into an artery. We really want that to be as clean as possible. Feel for the pulse with your fingers, not your thumb. Your thumb has its own little pulse, so you don't want to be feeling your pulse and not the animal's pulse. And Then once located, it is nice to do the artery walls are quite thick, unlike veins. So it is nice to do a little nick in the skin with a fresh needle so that you don't blunt your catheter going through that skin. Insert your catheter at a 45-degree angle, not that different to placing a venous catheter, but you're not holding it up or anything like that. You are just literally feeling and then poking. And you're going totally by feel. You can't see it. It's just a poke. And then if you see blood in the hub, always just stop for a second because we don't want to go straight through. So then once you've seen the blood, you can straighten out your catheter and gently advance into the artery. If the blood continues to flow into the catheter, you can advance off the stylet. Place a dry swab underneath the catheter to keep it clean because that blood is going to come gushing out. You can try and get someone to hold it off. It's very unsuccessful usually. And then place the teapot on and tape as per your practice policy. Place an aquafilm over to make sure the area remains clean and flush to confirm your position. And always label with an arterial line sticker because we don't want to put any drugs through there. The only thing you want to put through there is flush. You're then ready to attach to your pressure transducer and measure some invasive blood pressure. So this is what one of our transducers looks like. And the arterial line is connected to the pressure transducer via a non-compliant line, usually filled with just normal saline, or if it's quite a small catheter, you can use heparinized saline as well. And that just acts as a column that transmits the arterial pressure changes. The arterial wall expands and contracts with each heartbeat, and that changes the pressure in the catheter and in the line that's attached to the catheter. Inside the transducer is a flexible diaphragm and strained gauges on either side, and that's what gets called a Wheatstone bridge. Pressure changes in the artery push up against that diaphragm and it deforms and alters the resistance in the strain gauges. And then the Wheatstone bridge converts the resistance straining into voltage signal. And then that's when it shows us the graph and calculates the systolic, diastolic, and mean blood pressures. The signal is amplified and processed by the monitor, basically, as I just said. And then, yep, it changes into a waveform. So this is what one of the waveforms looks like. But before starting to measure, we do have to zero this transducer to make sure that we're getting the correct numbers. So it needs to be zero to atmospheric pressure. So we pop it, the transducer at the level of the patient's right atrium as best that we can. So if the patient's on its back, we sometimes have to raise that transducer up. And that's just best for accurate readings. And then we have to open up the transducer to the air briefly and zero it to make sure that we're getting accurate readings. So the graph looks like this. So this is like one of your signals, and there's three parts to that. So the ventricular ejection is when you've got the sharp up rising, and then you've got the diacrotic notch, which is basically the aortic valve closing, and then you go into diastole. So the mean arterial pressure is always accurate as long as you have a reasonable trace of that. But you've got the part which is systole, so you're going up, and then the diastole is when it comes down and relaxes, and then it repeats. So when you have, so the second diagram just below, you've got your normal trace. Your traces can get over dampened or under dampened. So, I'm going backwards, sorry. So your over dampened waveform sometimes can be because you've got air bubbles in your lines. There's a little fibrin clot at the end of the catheter, which just needs to be flushed away. You've got kinked tubing, or your tubing is too long and compliant, because we want that non-compliant tubing. And then your underdamped waveform, you can sometimes, the causes can be extremely stiff, short, or non-compliant, too non-compliant tubing, or you can be having monitor or transducer issues. Yeah.
What is non-compliant tubing?
So your non-compliant tubing is that it's not gonna just do what you want it to do. So like your fluid lines, if you wrap them in a circle, they're just gonna stay in a circle. Yeah, so you can kind of do what you want. So the non-compliant tubing, if you try to wrap it around something, it's just gonna be like, no, I want to be in the position that I want to be in. Okay. So it'll just kind of straighten back out again. More rigid. Yeah, more rigid. And that is the end. So is there any other questions?
The artery and the cattails, where
It's basically midline. So yeah, so on the dorsal, so if you've got them on their backs, you've got the tail, just have their tail out straight, and you should just be able to just feel it like midline. Yes. Yeah, on the base of the tail. Yeah. We got any other questions at all? We can move on to Melissa's, which is hypotension.
Sorry, Francis, I've got a quick question.
Yeah.
How long can you keep the arterial line in for? Like, is this something that you need to, like, obviously we need to regularly maintain it, but is it like we should just keep an eye out for, like, every 3 days, should we be considering replacing it, or
so
how does that work?
The ones that we tend to place under anaesthesia are kind of short stay arterial catheters. So they will essentially stop working probably within 24 hours. They will just get a little clot or something. They just won't flush, dislodge a little bit. You can get longer stay ones, which you can actually suture in. And yeah, that would be very much like central line care and probably like removing after 3 days. Yeah.
Thank you.
Is there any other questions before we move on? Yeah, that's not what I used to. Thank you.
very good. How do I do this now?
We can just change it over. Sorry guys, we're just going to do a quick changeover for everyone that's, if you guys want to grab snacks or a drink or something, please feel free. I can change it over for you, I think.
Yeah, I also need to just mute us for a second.
Just a couple of people having a quick bathroom break and grabbing some snacks for those people online. So we will be back within a few minutes.
Yay, thank you.
Would our online friends like some entertainment?
Of course.
Oh, spectacular. Thank you. Thank you so much. I live for this stuff. Alrighty, let's just stick with the theme of groups of animals. Anyone who's in the room live is also welcome to shout out their answers.
We can.
All right. Wonderful. Here's a good one for you. What is a group of hippos called? Ooh, no cheating, anyone? No cheating.
Oh,
Here's a couple of hints. It's highly related to those moments where you eat way too much ice cream.
Bloated?
Oh, great. Yes, it's called a
no
bloat.
way.
A bloat of hippos. Spectacular.
That's so good.
Alrighty, next one. What is a group of sharks called? Do we have any shark lovers in the group?
Me,
know
I love
one.
sharks.
Me too, but I'm like,
Oh, you love sharks? Did someone just throw an answer out?
No.
All right. Do we need some hints? Let's see. It's something that happens to me every time I go in the water in Sydney.
Good.
Do you pee yourself?
That's exactly it. It's called an inappropriate urination. No, it's I'm a Queenslander, so I like the warmer weather up north. So when I hop in the water in Sydney, I tend to
Freeze.
yeah. Shiver, that's it.
Shiver.
The shiver of sharks.
All right. I think we're all back now. So
Wonderful.
Oh, no.
All right.
Sorry,
So
guys.
sorry. If you want more, if anyone wants to, get some more fun facts after this session, just let me know. All right, back to you guys. Thank you.
thanks for that, Kelly. That's great. Cool. So hi guys, I am Melissa. I'm going to teach you guys about how to manage hypotension with our patients under anaesthesia, and how to troubleshoot some things as well. So we are going to cover why does hypotension occur in our patients, the practical causes of it, how to treat these, and then we've got some fun case scenarios as well. So you guys can kind of get involved and hopefully figure out what to do next. So just very quickly recapping what Francis has done. So just what is blood pressure? So this calculation of our blood pressure equals our cardiac output times our systemic vascular resistance. This is going to keep popping up quite a few times in the theme of our talk, because it's very important, and depending on which part of your blood pressure is affected is by this and how we're going to treat it. And then just quickly, just some ranges on our mean, our blood pressures just are on our oscillometric readings. Just as a quick note, as Francis has said as well, like anaesthesia affects all of our body functions and organ systems, and our goal under anaesthesia is to keep the body within its normal physiological limits. And when we're doing this blood pressure monitoring, it's vital in that. Oh, it's done what it did too. Okay, cool. So why does blood pressure matter to us? So does anyone remember our magic number for our blood pressure, our mean blood pressure? 60, yeah. And then yes, 90, whoever shouted that out, is for if we've only got our Doppler. And why does our hypotension matter? Anyone know? Perfusion for the brain.
Yeah, perfusion, and then our big one is going to be our kidneys. So because knowing our blood pressure, this reduces the risk of an AKI, and then, as Francis mentioned, a CKD in later life. So what we want to do is keep those kidneys nice and healthy, because any GAs we do for our patients and we don't know they're hypotensive, is going to potentially then give us issues in the long run, especially when they are getting a lot older. So how common is hypotension under GA? Does anyone roughly know what percentage of patients it affects?
60.
Not 60, but it's 20 to 45% of our cats and dogs have hypotension under GA. It does go as high as 50 if we have any of our high-risk patients. So if you get like a septic abdomen, a foreign body, if they're in like a true hypovolemic state, and especially our geriatric patients as well, especially if they've got that CKD potentially underlying as well. And it is one of the most common and frequently encountered complications.
Just going back to this again, so we're going to go through the 3 main things that affect our blood pressure and then what causes them while our patients are under anaesthesia. So our first one is our cardiac output. So anaesthesia causes direct cardiac depression. So can anyone think of what could cause our cardiac output to decrease? Yeah, exactly that. All of the drugs that we pump into them. So we have our induction agents, so propofol, alpraxolone, we have our ISO and SIVO, and these are going to be very common occurrences throughout the pathway. Our opioids, so our methadone, if we're giving fentanyl and things like that, and then bradycardia as well. So our all of our drugs that we use can cause bradycardia as well. So our opioids can cause bradycardia, and then if we're using our alpha-2 agonists such as medetomidine and dexmedetomidine. Bradycardia can also be if we've got our brachycephalic breeds as well. They generally have higher vagal tones, so sometimes they can have lower rates. Then we've got vasodilation. Can you think of any specific drugs that can cause vasodilation? Yeah, ACP. Medetomidine, kind of, yeah. Any others? So our biggest one is going to be, ISO. This is such a potent vasodilator, and this is going to be most of the cause of our vasodilation. We've got ACP as well. That is another very potent vasodilator, especially when it's mixed with ISO or SIVO. Propofol and our alpraxolone, both of them do vasodilate as well. And then if we're doing any epidurals as well, if you have a travelling surgeon that comes and does epidurals for any orthopaedic procedures, or if you guys are able to do your vet to do them yourself, when you're using a local anaesthetic such as your bupivacaine or lidocaine, this causes massive vasodilation, especially alongside your ISO. So it's just important to have that in mind when you are anaesthetising your patient. And then just going to touch on this picture. So this is a really great picture that shows our vasoconstriction and our vasodilation. So there is the same amount of blood in both of these vessels. When the vessel is more constricted, there's a higher blood pressure as the blood has to work harder to get through the vessel, so it's kind of steaming through. And then when the vessel is more dilated, the lower the blood pressure, as the blood doesn't need to work as hard. It can kind of just bimble along, and it doesn't need to get anywhere any quickly. This then leads to pooling of blood in our peripheral vessels, which we also do not want, as well as the low blood pressure. And then we have hypovolemia. So does anyone know what hypovolemia is? Yeah, low blood volume, perfect. Yeah, so this is when there is not enough volume in the vessels, and this affects our venous return when it goes back to the heart. Even if your patient is very vasoconstricted, if you don't have enough volume going through your vessels, you're still going to get a bad blood pressure. Any ideas what can cause it?
Trauma.
Trauma, yeah. So what the main ones we've got is blood loss. So yeah, if they've had some kind of trauma and they've had a catastrophic bleed, or even in surgery, if you've had like a spay and the ligatures come off and you're getting some bleeding, sometimes you can get abdomens and stuff full of blood. You've got vomiting and diarrhea. So why it's really important to ask the owners if they've had any vomiting or diarrhea within the last couple of days. It creates lots of fluid deficits, and then that can cause you to have hypovolemia as well. And then you've also got dehydration. If they're dehydrated, there is less extracellular fluid, which makes the blood thicker, and it's then harder for the blood to then go through the vessels nicely. Just to find out about your patient's kind of dehydration status, we generally do a PCV-TP before any anaesthesia. That is going to tell you kind of how kind of viscous your blood is. So when your PCV is higher, it's going to probably be a lot thicker, and when it's lower, it's going to be kind of more fluid through, and it's going to go easier, and that could help. If you think your patient is really dehydrated, being able to fix that before you go into surgery is going to make your life 10 times easier when you're actually in surgery, rather than needing to fix it when you're asleep. So causes of hypotension in practice. So what can cause our hypotension under GA? So they could be too deep, which is never good, and that causes a lot of vasodilation. Bradycardia, which can be caused again by all of our drugs, our backies, things like that. Our patient positioning. Have you ever had like a patient which is kind of in lateral, and then all of a sudden you pop it on his back and then his blood pressure plummets? Yeah, we're going to go through all of these in detail, but it's just an important thing to know. Hypothermia and blood loss. So we're going to go through all the treatments now of hypotension, and it's just important to know that there isn't one drug that fits all. It would be amazing if we had this one drug that fixed everything. It would make our lives so much easier, but unfortunately we don't. And it is very dependent on the cause and the patient, and it can also differ to what you have available in practice and what your vet is used to. So some of the things I'm saying, some vets might feel uncomfortable with, so just kind of have a good communication with them and then figure out a plan together. So too deep. How do we know if they're too deep? What kind of clinical signs can they give us? Position of the eye. Yeah, position of the eyes. Anything else? Yeah. So where the pupils are, if they're central. Anything else? Jaw tone. Yeah, perfect. So there are big ones. And then what can we do if we think they're too deep? ISO. Yeah, perfect. Turn down our ISO. So that is going to be one of our biggest factors in any GA is our ISO. And it's just really important to know our minimum alveolar concentrations for these drugs. So that is 50% of animals in a study they were gassed down with ISO, kept on a set amount. They tail clamped their tail, which is really mean. And if they reacted or didn't react, and 50% of those patients did not react. So for a cat, that is 1.6, and for a dog, that is 1.3. So they're just good numbers to have in the back of your head, just to know that instead, if you're on 2 or you're on 1.5 for a dog, then you might be able to go down a little bit. All of our drugs that we give as pre-meds are max sparing. So all of our methadone, medetomidine, even ACP is max sparing, midazolam. What does that mean? So it means that we can turn down our ISO because it reduces the MAC number. So if our number is 1.3 in a dog and we're giving all these extra drugs that make them sedated, yeah, we can go slightly lower with that. So with this study, they were literally gassed down with ISO and maintained, so they have nothing on board. Whereas we're giving them medetomidine, which we know is a sedative, and the methadone, which is a sedative and an analgesic, we're able to turn that down a little bit more. Yeah, keep an eye on your patient when you do turn them down, but there's quite a lot of times where you can go a lot lower than what you think, especially if you if you're on 2%, you can go down quite far. And then we've got bradycardia. So do you guys know there's 2, I'll give you a hint, of any drugs that can treat bradycardia? They're the most common one. Atropine, yeah. Yeah, and glycopyrrolate. Look, I can't even say the word myself. Glycopyrrolate, yeah, perfect. So these drugs increase our heart rate, which then in turn increases our blood pressure. Atropine has an onset of 1 to 2 minutes, and glyco has an onset time of up to 5. Sometimes you can see an AV block, and that is where the atriums are contracting quicker than the ventricles. But after about 5 minutes, this should disappear on its own. With no drugs, yeah. With both, or with both? Oh, sorry, yes, with both drugs. Yes, you can see it with both. Bradycardia is very common and it is easy to treat. Just on a side note, if you have given medetomidine, this vasoconstricts them, and then this is what causes the bradycardia. So the bradycardia can continue even after the vasoconstrictive effects have gone, especially in things like your DAXIs, your brachycephalic breaths, and things like that. So even I had a dog today, funnily enough, that I gave medetomidine. 3 hours later, I still had a heart rate of 30. So it's just something to note. So just because your heart rate's low, if your blood pressure's low with it, you need to treat it. So blood loss. Does anyone know how we would know our patient has lost a lot of blood? Yeah, gum colour. Anything else? Yeah, more like in surgery. Yeah, blood pressure, yeah. And generally they go quite tachycardic. So if they're in a true hypothalamic state, we would probably be able to see the amount of blood loss. There'll be some over the floor, some on the table, swabs, suction if you have that, and they will go tachycardic. So what can we do? Generally, we can treat them with fluids. So we want to give them an isotonic fluid, generally Hartmann's, that's what we use. You then can initially replace this fluid. So in cats, you'd give 3 to 5 ml per kilo boluses up to 3 times, and in dogs, you'd give 5 to 10 ml per kilo fluid boluses. If your blood loss is over 20 to 30%, you would need to consider potentially a blood transfusion. You can, to get you by, you can put lots of Hartmann's in, but eventually you're just going to dilute the blood down, and then your PCV then will drop lower, and then your oxygen carrying capacity will then decrease. So you just need to have that in mind. And just one note, if you give a fluid bolus and then it increases your blood pressure, but then all of a sudden it will go down again, that could mean that your patient isn't actually hypovolemic. It doesn't need those fluids. So what your vessels will do is your blood pressure will go up because you're increasing the amount that's going into your vessels, so that there's more blood flowing through, which will increase your blood pressure, and then the vessels don't necessarily need that fluid, so then it will get it out of the vessels and it will go to the other tissues. If a fluid bolus works, you should see the tachycardia start to resolve. And then hypothermia. So hypothermia decreases our cardiac output again, and it causes vasodilation. So it's just important to know, going back to this MAC number, if for every 1 degree that your patient is hypothermic, your MAC also again decreases. So if you have a patient that has a temperature of 36, your cat's MAC goes from 1.6 to 1.4, and then your dog goes from 1.3 to 1.1. So it is quite a dramatic drop. So it's just one thing just to be, again, just to have in the back of your mind that if your patient's cold, then their kind of requirements for the drugs get lower. And then patient positioning. So as we kind of touched on earlier, you have your dog or cat in lateral, you all of a sudden pop them on their back, and then their pressure plummets. So this is due to affecting decreased venous return. So your arteries are quite thick and they have quite big walls, and they're very hard to kind of like flatten essentially. But your veins are not. That's why they're so easy to get like IV catheters and things in. So if you put your patient on their back and they have a distended abdomen, they're pregnant, and they've got a large abdominal mass, this takes up the pressure in the abdomen and then depresses our vena cava, and then that then decreases the amount of blood that then go back to the heart. Another big one as well is our surgeon's hands. If you have a surgeon with very big hands and you've got a very, very small patient, or you've got like a abdominal mass that's quite big and they have to move their hands around quite a lot, you can see drastic changes in their blood pressure. So it's just really important to communicate with your surgeon, where if you've got a very strange reading and then it's come back up again surprisingly, just ask them what are they doing with their hands, where are their hands in their abdomen, just so that they can just be slightly mindful of it.
Where would they be applying pressure to?
So it's your vena cava and your aorta run kind of parallel to like your spinal column. So if their hands are quite deep in the abdomen, or you've got like a large abdominal mass, or even like with a GDV, if their stomach is quite big and they're trying to like twist it and things, then they can like depress that, yeah. And then patients that it can apply to are obese, they've got large abdominal mass, pregnancy, they've got ascites if they've got a lot of fluid in there as well. So we'll just touch on a few of our drugs that we've spoken about. So we've got our anticoagulogenic drugs, and then this is our atropine and our glyco. So these increase our heart rate. You generally want to use these drugs when they are bradycardic and hypotensive. If they do have a normal heart rate, you can give these drugs, but it will increase your heart rate a lot. So you don't, again, going back to, we want our patients to try and stay in their physiological limits, like the normal physiological state. If they've got a heart rate of 100 and our pre-op exam was 100, that heart rate could shoot up to over 200, which is then just going to exert more pressure on the heart. The dose for our atropine is 20 to 40 mics per kilo IV, and our dose for glyco is 10 mics per kilo. We then have our dopamine. So this is an inotrope, and this increases our heart's contractility. So just say you've given some glyco or atropine, it's kind of done the job for a bit, and your heart rate's now at a good steady level, but your blood pressure is still dropping. We don't think it needs a fluid bolus or anything like that. This will help increase that heart's contractility to get that blood out of the heart easier, and then increase our blood pressure in return. This is to only be given on a CRI only. It's quite a potent drug, so if you bolus it, you kind of causes all sorts of effects with the body. So it's best on a CRI, and that's 5 to 10 micrograms per kilo per minute. You start on 5, and then you can just titrate it up slowly until you get the desired effect that you want, and then you would just keep them on that for the rest of the surgery. You can then titrate it down if need be, but generally once they're kind of happy on it, you can keep it on. And then we have our vasopressors, which is our alpha-1 agonist. Now this is for pure vasoconstriction of the vessels, and this is a drug called noradrenaline. So this constricts our vessels and helps that blood flow through them faster to get our better blood pressure. It's one thing to note with this drug, it can, if it goes extravascularly, it can cause necrosis of the tissues. So this is a drug that we use very lightly. It's not, this is kind of like we have no other ways of getting our blood pressure up when we use this. Ideally, you'd want a separate IV because you don't want this to go be flushed in with anything else. You start at 0.1 and then you can titrate up, and then you titrate it up until you see the effects that you want with your blood pressure.
At what point would you consider using the other drugs?
The dopamine and the noradrenaline. So dopamine, if I've used glyco and atropine and my heart rate's up at a normal level, so just say for a dog whose pre-op heart rate was 100 and it stayed at 100, but my blood pressure is still quite low, then I would use dopamine. I would use
after a specific time it still hasn't changed, or
it's kind of case dependent, but kind of seeing what your patient's doing. If you've turned down your ISO, you don't think you want to go any lower on that, you've given extra analgesia so you know that it's not painful, things like that, then you can go on your dopamine. Your noradrenaline is kind of last effect. I've tried my dopamine, I've tried all of my atropine, glyco, my ISO's on next to nothing, and you just really need that vasoconstriction. And I'm just going to touch on, it's not on here, but I'm just going to touch on medetomidine. So Medetomidine technically isn't a treatment for hypotension, but it can aid in vasoconstriction. So if you think that it could be because you've got your ISO a bit high and you need a bit more of like a sedative, you can give 5 mics per kilo of medetomidine IM. You don't get the kind of massive bradycardia very quickly, it's more gradual, but then you do get the vasoconstriction that you need, and that can help to get you out of a bind if you're trying to think about it as well. If you are already bradycardic, err on the side of caution, because it could be the bradycardia that is causing the hypotension, and you also then don't want them to go more bradycardic as well. So we've got this lovely chart, and we have them for you to take back to your practices as well. And it's just a little flow chart on what to do and when to do it. So it's, if you're hypotensive, assess your depth, check your cuff position, and if you think you can reduce your inhaler, it gives you some ideas on what to do. If we think it's your heart rate, if they're bradycardic, normal, and tachycardic, we're giving you some ideas as well. And then it does go over the dopamine and the noradrenaline as well on when to give it. So you guys can take those home that are here. And then now we're just going to go through some scenarios. So we have Doris, who is a 5-year female neutered domestic short hair. She's eaten some hair bands, which cats notoriously love to do, and she's got a lovely foreign body. She's otherwise healthy and she has no other issues. So we're going to pre-med her with some methadone and some medetomidine, and she's just having alfaxolone IV to effect. So she's been asleep for a little while, and then this is our screen. So our mean blood pressure currently is 82 with a heart rate of 81. What's our thoughts on this? Do you think we need to do anything? Are we happy with it? Are we not happy with it? So if we go from like the heart rate first, what do we think about an 81 heart rate for a cat? I think that's a little bit bradycardic, yeah. But then we look at our blood pressure, and we have a mean of 82 and a systolic of 108. Do we think that is an appropriate blood pressure for our cat?
Well, we said 8, didn't we say 90 systolic equated to about
90 systolic,
oh, no,
and it's 60 mean.
systolic, so
Yeah.
it's still up.
Yeah, so our systolic is 108, our diastolic is 68, and then our mean blood pressure is 82. That's a pretty good blood pressure for a cat. Probably that medetomidine working quite well. So at this stage, I wouldn't do anything with this cat. I know it's very scary to have a cat with a heart rate of 81. And trust me, I've definitely been scared multiple times. But our blood pressure is great. We don't need to increase our heart rate currently because our blood pressure is doing really good. So then now our heart rate has gone down to 73, and our mean blood pressure has gone to 54, with a systolic of 81. What do you guys think about that now? Yeah, definitely. Our heart rate's really low, and our blood pressure is really low. So what do you think we can do for that? Yeah, definitely.
Assess the depth.
Yeah, assess the depth, turn down the ISO. So we've turned down the ISO and it hasn't really done much else. What could we give? Yeah, great. Yeah, atropine or glyco. So we can give atropine. So we'll give atropine at 20 mics per kilo. And then this is now our screen. So we have a heart rate of 168, and we've got a great blood pressure of a systolic of 159 and our mean of 129. So we fixed it. Yeah, that's great. Do you think we need to do anything else with this cat? So we've just given atropine, so we would expect. We've just given the atropine, so we would expect this general thing to kind of happen. You will see they can go quite tachycardic, and they can go quite tachycardic quickly. Sometimes it will take up to a good 3 to 4 minutes, and then you will then see your next couple of blood pressures go up, and then they should start to taper down and then become slightly more normal. But it stayed kind of like this for the rest of our GA. So she's pretty happy now, and then she's woken up really nicely.
You've had the previous blood pressure reading. Treated it.
Yeah.
What does systolic diastolic mean? They were to aim.
So we're going to aim for normal. So we want, this is probably a little bit hypertensive, which you can see. So initially they, with the heart rate, because it goes up so quickly, they will get a little bit hypertensive, and then it should go down.
So what's your?
We still want to remain normal. So our mean, we want to be between kind of like 90 and 60. Our systolic, we want to be around 120, 130 to about 90.
I just have a question online.
Yeah.
When would you use atropine over glyco, or are they fairly interchangeable for hypotension with bradycardia?
They're fairly interchangeable. It also just depends what you have in practice as well. If you have both, use which one you feel more comfortable with. But yeah, if you have only one or the other, just use which one you have in practice. The only time I would probably say if to use atropine over glyco is if your heart rate has decreased very quickly and you think they're having some kind of vagal response. Use atropine just because it's quicker acting. Cool. Do we have any other questions on this? Yeah.
So with the dopamine, is there any contraindication to patients that are on cyclin, for example?
No. So
Or does it affect your dose rate?
Doesn't affect your dose rate. Still start low, and then increase it. But it should help if you've got dogs with mitral valve disease. It should help with that contractility. They generally have slightly, they can have slightly thinner walls of their ventricles. So it will help them to actually contract and get that better. And then we're just going to have another scenario. So this is Lucy. She is a 1-year female entire golden retriever in for her stay. Again, she's healthy, no underlying issues. So we've given a methadone and metformin pre-med again, and we've just done propofol this time. So this is our screen. So she's got a heart rate of 112, and then she's been under for about 20 minutes, and then now her blood pressure has got a mean of 45 and a systolic of 73. So what do you think we could do? Yeah, I probably should have said her depth is good, but she's on 2% ISO. Yeah, so we'll turn it down, and we've turned her down to 1.5, and then we're going to monitor her. We've waited 5 minutes. Heart rate stayed the same, but then her blood pressure has come up slightly more. So we're on 1.5 ISO now. Can you think of what would you do next? Do you think we could turn her down more? Yeah, we could do fluid. The only thing that would stop me from doing fluid currently is that it was very responsive to the ISO. With all of the drugs and things that we've got on board, I would turn down even more. Yeah, so we'll turn down to 1.25. And then our next blood pressure reading is a mean of 78. She's stayed stable. She hasn't reacted at all, but her blood pressure stayed stable on 1.25. So then she goes out for the rest of the GA and we don't have any issues, which is great. So just a couple of take-home points of treat all of your patients individually, especially if they do have things like mitral valve disease, or if they're younger, if they're older. Everything you're going to do for them is different. It's very, very common. So if you don't, we always want to be making sure we are measuring our blood pressure under anaesthesia. Check the position of your cuff and move it to a different limb if you are worried initially. Turn down the ISO. If they're bradycardic and hypotensive, get that heart rate up because that is going to help. And if they are tachycardic, check for your blood loss and give fluids as well if you need. Anyone have any questions? the end. Cool.
Do we have any questions online? Wonderful.
Great. Thanks, guys.
Well, thank you to everyone who attended online. We are going to finish the call here if there's no more questions. And I hope we see you all at our next one.
Thanks, guys. That was great.
Thanks,
Yeah,
guys.
thanks
That was
so much,
awesome.
Ellen, That was really awesome.
Thank
That was
you.
so
That was
fun.
great.